Bom dia a todos. Saúdo a todos nessa novo Grand Round virtual de hoje, cujo assunto será The Pandemic Before the Pandemic, Diabetes Mellitus as a Continuing Threat. Nós teremos convidados especiais de fora do Brasil hoje, além de professores aqui da Universidade Federal do Rio Grande do Sul e do Hospital de Clínicas. Esse Grand Round será liderado pelo professor Rogério Friedman, terá a participação do professor Fernando Gershman, e a participação do Dr. Stephen Ken, da University of Washington, e do professor Per Henrik Groep, da University of Helsinki. So, we welcome you here. Very nice to have you here with us. Eu vou passar a palavra agora para o professor Rogério Friedman para liderar esse Grand Round. Muito obrigado.
Thank you, Professor Berger. We are very grateful to Stephen Kahn and Per Henrik Group for having accepted our invitation. You know, they are long-lasting friends of our hospital. They know they have been exchanging experiences and research with us for a long time, and it's a great privilege to have them with us. Okay, I see that now Per Henrik has managed to join us. Now, diabetes, as you know, is a major public health problem. We have currently probably something in the area of 470 million people adult people suffering from diabetes in the world. Like in Brazil alone, between 15 and 16 million patients. 1 in every 10 people in the world are living with diabetes, and when we say that people either have diabetes or they live with someone close who also suffers from the disease. It's a major challenge, and as this week on the 14th of November is the World Diabetes Day, we have chosen to hold this grand round focused on the theme of diabetes, and we have a super team of speakers that will help us understand and broaden our view of the problem. We'll start with Professor Fernando Gershman, that works at Hospital de Clínicas at our endocrine unit, then followed by Professor Stephen Ken, and finally Professor Per Henrik Group. The presentations will follow the usual schedule, and we'll leave time for questions, answers, and comments by the end. So we'll go straight on, and I invite Fernando to start his lecture straight away. Fernando. Fernando, please turn on your microphone.
So I'd like to thank Rogério and the hospital for the invitation to represent our unit on this grand round. So I go directly to my presentation. So are you seeing my screen?
Yeah.
Okay. So I will start with the numbers of COVID-19 in Brazil in the beginning of November. So we have now 10.9% of all cases in the world, 12.7% of deaths in the world, and these are the numbers of the state of Rio Grande do Sul of deaths. So we are approaching 6,000 deaths today, and these are the comparisons of the mortality of the state with the mortality of the countries of our guest speakers. And these are the numbers of cases per week since the beginning of the pandemic in Brazil. You're going to see that the pandemic had reached a peak, and now it's having a reduction of the incidence of cases, but we are expecting a new peak in the future. So I elaborated 4 questions. Each one of the questions I will try to answer with 1 or 2 studies on the relationship between diabetes and COVID-19. The first question is if diabetes is a risk factor for mortality during infection with SARS-CoV-2. And although there are several meta-analyses showing that there is a relationship between the presence of diabetes and mortality for COVID-19, I believe that this is the best study that was presented until now. So this is a population-based cohort study of the whole population of UK that the investigators assessed data of the patients that were admitted in the hospital with COVID-19, and they assessed the reasons for their mortality. As you can see here, these are the numbers, the deaths per 100,000 people, and you can see these across ages. And so, in comparison with the overall population of UK, and though in blue, and the population without diabetes in purple, people with type 1 diabetes and type 2 diabetes had a significant increase in their mortality related with COVID-19. The same group also assessed the whole population in the public health system, in the primary public health system of UK, and compared the rates of mortality of this population regarding diabetes, type 1 diabetes and type 2 diabetes. And the comparison was made in 19 weeks of 2020 in comparison of the number of deaths of people with diabetes between 2017 and 19 in the red line here. So as you can see, this is the death rates in 2017 and 19 in the red line. And in the blue line, it's possible to see the deaths not related to COVID-19 in people with diabetes. And we also can see the total number of deaths in green. And so the difference between the total number of deaths and those deaths not related with COVID-19, that is represented by this gray area under the curve. It's the number of people that died of COVID-19 related with diabetes. And as you can see, there was a major increase in the death rates of people with diabetes when they had COVID-19. The number of deaths was 60% higher of people with diabetes during this period of time during the pandemic, and 64.3% in subjects with type 2 diabetes. It's interesting also to say that the number of people that die not related to COVID-19 with diabetes increased in this period of time. And this is probably an adverse effect of the pandemic because people did not look for assistance during this period of time. The second question is if COVID-19 is causing diabetes and or worsening hyperglycemia. For this question, I choose 2 studies. The first study was performed in Italy in the tertiary diabetes centers of Italy. And they assessed in people under 14 years the presentation of diabetes. So what they show? They show that diabetes ketoacidosis at presentation in comparison of the years of 2020 and 2019 was pretty similar. And the severity of DKA in new cases, the prevalence of the severe DKA in new cases was also similar between these 2 years. What was different was the number of cases, new cases of type 1 diabetes. In 2020, there was a reduction in the rate of new cases of type 1 diabetes in Italy. But in the opposite direction, cases presenting with severe diabetes ketoacidosis increased in 2020 in comparison with 2019. So this data suggests that people was afraid to seek for assistance, and this prolongation of their time to seek for assistance decreased the numbers of people in the beginning with new cases of type 1 diabetes, but increased the presentation of severe cases of people with type 1 diabetes. So this data also was assessed. This question was also assessed in a Germany analysis, where you can see here in the blue line. In the blue line here in the center of the plot, that was the number of cases expected of new cases of type 1 diabetes in the last 10 years in Germany. And you can see that in 2020, the number of new cases in Germany of type 1 diabetes was pretty similar with the number of cases in the last 10 years in Germany. So this data suggests that COVID-19 is not related with new cases of type 1 diabetes as reported in several reports in different countries, suggesting this association. I believe that this needs to be studied in the long term, because we know that epidemiologically talking, that the association between viral infection and the development of type 1 diabetes takes time and needs 1, 2, or 3 years to be identified. So I believe that in the next 5 or 10 years, epidemiological ecological data needs to be performed to see if there is an association between COVID-19 and new cases of type 1 diabetes. The third question is if the achievement of a strict glycemic control is a potential target for prevention of complications and death related to COVID-19 infection. So for this, I choose a retrospective analysis of the province of Hubei in China that show that those people that were admitted to the hospital with COVID-19 and diabetes, when they presented with well-controlled blood glucose and they considered this glucose variability that did not reach 180 milligrams, they performed better and they had a greater survivor than those that reach a glucose variability greater than 180. And in another study, it was compared the survival rate of subjects with diabetes admitted to the hospital, and when comparing to people with normal glycemia, those with diabetes had a worse survival rate, and even more, the survival rate was reduced in those that presented with hyperglycemia induced by stress while these people were admitted in the hospital. The last question is how different factors relate to mortality on this relationship between diabetes and COVID-19. For this, we are coming back to the UK cohort study. And in this data, we can see that in type 2 diabetes and type 1 diabetes, an increase in A1C, a decrease in renal function, and the extreme of BMI, so low normal BMI and undernutrition, or a BMI compatible with obesity were related with increasing risk of mortality on this population. The cut points that were associated with increasing mortality were an A1C of 7.5 in type 2 diabetes and greater than 10 in type 1 diabetes. We also need to address the issue of the treatment that we are doing with our patients with diabetes. There are several medications that we use not only for glycemic control, but also for blood pressure control and lipids that affect inflammation. And inflammation is a key factor in the pathogenesis of complications related to COVID-19. So now there are several studies that are addressing if these medications affect the prognosis of people with diabetes. This is one of the studies that look at this. These studies are also from China, and they identify that the metformin treatment during COVID-19 infection was related with a 4-fold increase in lactate acidosis and also general metabolic acidosis. They also found that people using metformin with diabetes had a decreased rate of heart failure and a reduction in inflammation. But these factors did not change mortality after 28 days of admission in the hospital. So coming back for the question of this presentation, I do not believe that at this moment we know who is the chicken and who is the egg. Summarizing the findings of my presentation, diabetes is a major risk factor for COVID-19 mortality. It's modulated in part by age, body size, and comorbidities. COVID-19 does not affect the number of new cases, at least until the moment. Glycemic control and status during infection affects prognosis. So what are the recommendations to take for home for our patients? We need to achieve a good glycemic control in our patients. The retrospective data that we have until now suggests that this is a nice strategy to deal with diabetes at this moment. For this, it's necessary to optimize telemedicine and to convince our patients of the necessity to have assistance. We need to orient our patients, advise our patients to have supplies and medicines at home. They need to list their medicines, and they need to provide this list for their relatives and to put this list in their cell phone for emergency problems. And we need also to emphasize the importance of lifestyle change during this time of pandemics. Thank you very much.
Thank you, Fernando.
Let me try to take out the presentation.
Okay, just
it's here.
Now,
okay.
It seems that COVID-19 just added a new kind of worry for us as physicians regarding our patients with diabetes. It's a new pandemic, making an old pandemic more visible and more important. The thing is, if hyperglycemia is a factor for poor prognosis, perhaps if we could prevent diabetes from developing, we could be helping millions and millions of people. And so we invited Stephen Kahn to talk about this with a particular focus in very young people. It seems that we are gathering more experience in this way. So Stephen, if you could put your presentation on and start, we are ready.
Can you see it now, Rogerio?
I can see you, but I don't see the slides.
Oh, that's interesting because it said I was sharing. Let me try it again. Try one more time.
Okay, we can see it now.
Great. Okay, so thank you very much for inviting me to talk today. And I think I don't really want to say this for Pera, but I think my presentation pales in importance today with what Fernando just shared with us regarding the pandemic. And I think everything he talked about is really spot on. And we're all struggling with the same thing. So at least from that perspective, the world is united. In my presentation, which is titled, Can We Prevent or Reverse Type 2 Diabetes? How about the young? There are three embedded questions that I'm going to address briefly, and hopefully there'll be enough time for discussion subsequently. So to start with, here are my disclosures. And the first question is simply, can we prevent type 2 diabetes? And in this instance, we're talking largely about adults. And I show you on this slide a summary of many of the different studies that have been done that have employed largely lifestyle, shown up here in the left, non-thiazolidine-dione medications in the middle, and then thiazolidine-dione medications on the right. And you can clearly see from the arrows that indicate a reduction in the risk of progression from pre-diabetes or impaired glucose tolerance to diabetes, that the most effective approach is the thiazolidine-diones. But we also know that these medications come with a lot of potential problems in many people. And for that reason, they're really not used anymore. Aside from those medications, lifestyle, as shown here on the left in green, is the most effective approach we know, with most of the studies being relatively short-term, as I will share with you in a minute. And you can see that these four studies indicated here show that lifestyle works in people from China, people from Finland, people from the US, and people from India. So it would appear to us that this is effective around the world, and one would predict, therefore, that it would be quite effective in Brazil as well. In purple are shown a number of different medications that you can see here listed at the bottom. The metformin shown here on the left in the United States and in India has proven to be effective. And I'm going to focus now on my next slide on the data from the United States Diabetes Prevention Program, the DPP, which had a double-blinded phase and then a long-term follow-up to highlight some of these effects. So you see here the initial results of the DPP as indicated here by this arrow at the top. And what you can appreciate is that placebo is in red and metformin in blue. So these two groups were blinded in terms of their medications. And in green was the lifestyle arm, which clearly cannot be blinded. And you can see here on the right that lifestyle reduced the risk of developing diabetes by 58% in the approximate 3.5 years of average intervention, and metformin by 31%. Once the results were announced, we've been following these individuals in what's now called the DPP-OS, standing for Outcomes Studies. And what I can share with you today is the data through 15 years. We have now accumulated data that goes close to 20 years, which is very similar. And when one looks over the longer term, as indicated here, you can see that the curve is flattening out, probably because the number of people susceptible is getting less. And in the blue and green are the two interventions, which you can see also from the risk reduction that I've put here, are still very effective compared to placebo 15 years later, suggesting, therefore, that we clearly can do something and should do something with metformin reducing the risk at 15 years by 18% and lifestyle by 27%. Now, how do you take that and translate that into your clinical practice, which after all is the important question? And so here is a slide from data that was published a few years ago from the DPP, looking at subgroups based on their baseline hemoglobin A1C, less than 5.5, between 5.5 and 5.9, and 6 and 6.4. Start by looking at the placebo group, and you can see there's a nice step up, not that you would want that if you were a patient, in the risk, so that individuals whose hemoglobin A1C is between 6 and 6.4 who are assigned to the placebo arm, more than 20% of them will develop diabetes each year, compared to less than 5% if your hemoglobin A1C is between 5.5 and 5.9. And you can also appreciate that metformin and lifestyle are effective in reducing this risk by around about 50% in the group that are between 6 and 6.4. And while I'm not going to share all the details with you, let me just add, because this is important in clinical practice, that metformin was most effective in the people who were younger, who were heavier, and who had a fasting glucose that was elevated above 100 or 110, which was somewhere around about between 5 and 6 millimoles per liter. And that lifestyle was more effective in the older population in the study. And if you go back to this paper in Diabetes Care, you can get more detail. But clearly, we can do something. And I would say to you that if I had a hemoglobin A1C between 6 and 6.4, I would want you to do something for me. Now, the second question is, can we reverse type 2 diabetes? Can we intervene in these individuals early on or even later and reduce the risk of progression? So to address this, I'm going to share with you a couple of studies as well. The first one is now getting on to close to 15 years old, but I think it really was the initial study that pointed us in a direction that was completely new. And now you'll see here that I've highlighted the first 6 months of this study where this broken line is, and you'll see subsequently that the study goes out well beyond that time. Here are the 3 different medications that were used. Glyburide is an example of a sulfonylurea, metformin, and the rosiglitazone, the thiazolidinedione. And what you can appreciate is that in the first 6 months, the sulfonylurea was the most effective in lowering glucose in this cohort of individuals who had had diabetes on average for 2 years and were drug naive. Never before had they been treated at all with a glucose-lowering medication. You can also appreciate that at the end of 6 months, the metformin and rosiglitazone had not quite reached the lowest point. And if we followed these individuals out further while they were still on their medicines, what was revealing to us was the impact of these different drugs on glucose control over time. And you see that now, if I can get the slide to move, there we go, that while the sulfonylurea glyburide was the most effective, over time, glucose control was lost more rapidly with glyburide. And I would argue this difference between metformin and rosiglitazone is clearly significantly different, with a hemoglobin A1C percentage of about 0.5% between glyburide and rosiglitazone. Now, of course, again, we have the problem of the thiazolidinediones, that we don't use them anymore. But clearly, metformin as first-line therapy based on these data was certainly vindicated and was the approach. It helped this become the standard approach. And the use of glyburide, and I will add that all the other sulfonylureas show the same thing, is great initially, but it may even accelerate progression of diabetes. So while it's really cheap, it comes with downsides besides hypoglycemia. Now, there's a lot of interest in the approach of surgery as a means to try and reduce the risk of progression or slow progression. And I wanted to share these data for you, which come from Phil Schauer, who was at the Cleveland Clinic, who randomized, and this is really important, they did a randomized study. Most studies of diabetes and surgery are retrospective, or individuals choose what therapy they want, and then they look at what happens going forward. In this study, this was a randomized study. There was intensive medical therapy, so using as much medicine as one can, sleeve gastrectomy or gastric bypass. And you can see these individuals had more severe diabetes when they joined the study, a hemoglobin A1C of about 9. The intensive medical therapy drops the hemoglobin A1C close to the goal of 7%, but one loses control over time, as shown here in blue. With the 2 surgical approaches, you can also see that we get improved glucose control. If anything, based on the p-values for trends over time, it was better than the medical therapy, which is a good thing to know. However, against what many people had said, that we could cure diabetes, we could get remission, you can see that hemoglobin A1C increases over time, so that these 2 surgical approaches again result in glycemic control at the end that is above the goal of 7%. But what is also hidden in this paper that doesn't get discussed too much is the data I'm about to throw onto the slide. This goal of less than 7% was only achieved in half the individuals with surgery compared to 1 in 5 individuals with the medical therapy. But that half the group reaching that goal with the surgery occurred with these individuals on medicines. So that this use of surgery gives better glucose control than intensive medical therapy, but many of these individuals are still requiring medication. So we're not curing this disease. We may be slowing its progression some compared to those with diabetes, or more effectively treating them, because these slopes are not dramatically different. Now let's turn to my third question, what about the young, or how about the young? And when I talk about the young here, I'm not talking about where those of us who are on this call today could move ourselves back 15, 20, 30 years for people like myself and Rogerio, but rather talking about people who are teenagers, adolescents. And the data that I think is pretty scary to me and is the future scourge of diabetes that we have to worry about is these data which come from the United States, but are being seen all around the world, and I have no doubt are occurring in Brazil. The purple represents youth in the United States who are being screened for diabetes, and these are individuals here who were found to have type 2 diabetes, no antibodies, obese, etc. And you can see the average for the population in the US is increasing, shown by this purple line. Here in blue at the bottom is a population that is white or non-Hispanic, Caucasian, whatever term you want to use. You can see the change over time in these 10 years is not significant. But you can see for all the other populations shown here in the colors with the code here on the right, non-Hispanic, Black, Hispanic, Asian or Pacific Islander, Native American, the rates are increasing. And particularly in Native Americans and in Blacks, where you can see that at the time the study started in around 2003, if we just took these two populations, approximately 15 to 17 cases were being diagnosed amongst 100,000 youth. And here in 2012, it's 45 for the Native Americans, and it's somewhere around about 35 for the Black population. And as one looks at the newer data that's coming out, the graphic is not as nice, and so I haven't chosen it. These trends are continuing. So this is the next thing we need to be worrying about, because as I will show you in a minute, the disease is incredibly aggressive in these people. And in these young people, we're going to have to deal with them as they move through transition clinics from the adolescent clinics into the adult clinics. So what is the evidence that it's more progressive and more rapid? I'm not going to go through all the data, clearly it's not possible for time, but this was a study called Today, in which a group of youth, adolescents with type 2 diabetes, were treated with 3 different approaches. One of them is just metformin on its own. And the way this graph is structured, we're looking at the number of kids that did not need extra medicines, that didn't reach a primary failure. And if we say, how long does it take for half of them to reach the outcome of glycemic failure and need more medicines? It's about 39 months. So within just over 3 years, they were losing acceptable control with metformin. How does that compare to adults? And now clearly there's no head-to-head study, but I return back to that ADOPT study that I showed you earlier. Here are the proportion of adults, this is just an inverse, that are reaching glycemic failure. So rather than the number of people who maintain control, we look at the number of people who failed. And you can see that if we take that 39 months in the youth and extrapolate it, it's about 13%. So this would suggest that kids may be failing at 4 times the rate that we see in adults. But what is even more scary to me is these data. If we look at the 700 or 699 youth who participated in the study, at their baseline age, when they entered the study, they were 14 years and had diabetes on average for about 7.8 or 8 months. They were followed for less than 4 years on average. And when you look at the total number of cases here, so this is now when these kids are approximately 18 years of age and had diabetes for 4 years, a third of them have hypertension, 10% now have cholesterol levels that meet the adult criteria for elevation, a quarter have increased triglycerides, and nearly 1 in 5 now has microalbuminuria. They represent a time bomb of complications, and the longer-term follow-up of the study has already shown that some of these kids have had myocardial infarcts. So that type 2 diabetes in these youth is a bad outcome, or has bad outcomes. So how to summarize then the answers to the 3 questions that I posed? The first is that lifestyle and metformin can slow progression of pre-diabetes to type 2 diabetes in adults in the United States, and I will say of all racial and ethnic groups, with metformin more effective in the younger ones and lifestyle more effective in the older ones. Second, some of the currently available glucose-lowering medications, like the sulfonylureas, can accelerate perhaps diabetes. And I should also mention, which I didn't at the time, that data with the DPP-4 inhibitors shows exactly the same curve. And the question now is, does the GLP-1 receptor agonist curve look the same? And that bariatric and metabolic surgery can slow, but none of them can prevent the progression of type 2 diabetes. And thirdly, in youth with type 2 diabetes, the disease appears to be more aggressive than in adults. And with that, I'm going to end my presentation. Thank you very much. And Rogerio, it's...
Okay, Stephen, thank you for a fantastic presentation. Now, this is kind of worrying. I mean, we can slow progression to type 2 diabetes. We can reverse type 2 diabetes for some time, but not forever. Okay, we can treat type 2 diabetes, but we're still left with millions of people suffering from type 2 diabetes, and a smaller number of people have type 1 diabetes. And quite a few people are at risk for microvascular complications of diabetes, nephropathy, retinopathy, neuropathy. And if you have diabetes, you may be at risk of some complications. And if we can't prevent diabetes from developing, perhaps we can help people with complications to have a better outcome and live a healthier life. And this is what we invited Professor Group to speak about. Now, what can we do about the complications of diabetes, my friend? I'll present the slides for you. Is that right?
Yes, thank you very much. Can you hear me now?
Yes, perfect.
Great, okay. So this is a challenge. It's the first time I'm giving a lecture via phone, because I was not able to use the link that I was sent to me via the Google. But you know, that was a challenge, but now we are here. So thank you for inviting me, Rogerio. Hi, Stephen. Hi, Fernando. Nice to be on board. Have you on board. So my task here, next slide, Rogerio, will be to actually go through 3 points, important points. Next slide, please. And the first one is that diabetic kidney disease is common. The second one will be that the consequences of diabetic kidney disease are grim. And the third, we need to take action. So let's have a look at how common diabetic kidney disease is. Next slide, please. So if you look at this slide, which is at random screening for diabetic kidney disease. This was Hans-Henrik Parving doing this demand study throughout the world, screening for the presence of albuminuria or an eGFR below 60. And what you can see in the middle, on a global scale, one screening at random, every second person had signs of diabetic kidney disease. And if you go to the right of the global, you can see the figure for Asia, 68%. And right of that, Central and South America, 61%. It basically means that more than every second patient in your part of the world, in your countries, will have signs of diabetic kidney disease. So diabetic kidney disease is common. Next slide, please. So next question is, next slide, please. What are the consequences of having diabetic kidney disease? And you saw that already from the title slide. They are grim. That's true. If you look at this slide, what you can see is that these are data from the NHANES study from the US, and you can see that the excess mortality, that's above the dotted line. And you can see that if you have type 2 diabetes and albuminuria, you have a 18% increased excess mortality. If you have a reduced eGFR below 60, 24%. And if you have both, you have a 47% increased risk of premature mortality. So diabetic kidney disease comes with an increased risk of dying early. Next slide, please. But it's also, if you look at this slide, on to the left, you can see that the more albumin that leaks into the urine, and to the right, you can see that the less the kidneys function, the more likely the patients are to face a cardiovascular event. Next slide, please. And even more importantly, now when we have learned that heart failure is one of the real challenges in patients with type 2 diabetes, and especially in those with kidney disease. And that is explained in this slide. On the left-hand side, you can see that when you have a reduction in your kidney function, so you lose eGFR, you can see that the risk of ending up in hospital because of heart failure increases. On the right-hand side, you can see the more albumin that leaks into the urine, the more likely you are to end up in hospital because of heart failure. So heart failure is also a consequence of diabetic kidney disease. Next slide, please. Next slide, please. And you can see why then you can ask the question, why is diabetic kidney disease a driver of premature mortality, cardiovascular events, heart failure? Look at this slide and the list here. So anytime you have impaired kidney function in one of your patients, you will see hypertension, you will see oxidative stress, insulin resistance, arterial calcification, inflammation, accumulation of uremic toxins at the bitter end, left ventricular hypertrophy, endothelial dysfunction, activation of renin-angiotensin-aldosterone system, activation of sympathetic nervous system, anemia. What are these? These are risk factors for cardiovascular disease. So no doubt that people with type 2 diabetes that have signs of diabetic kidney disease, they will have grim consequences. Next slide, please. Next slide. Yes. So this slide actually tells you one of the most important stories here. So if you have a 60-year-old patient with type 2 diabetes in front of you in the clinic, you can just by having diabetes expect 6 years shorter life expectancy. If that patient has suffered a myocardial infarction or a stroke, you can expect 12 years shorter life expectancy. Now, if that patient hasn't suffered any cardiovascular events, but you find early signs of diabetic kidney disease, that equates to 16 years shorter life expectancy. So diabetic kidney disease is common. The consequences are grim. Next slide, please. So we need to take action. Next slide. What should we do? I've usually said that we need to be very pragmatic. The 5-finger rule, 5 fingers. What is the 5-finger rule? It basically means that optimal glycemic control, below A1C below 7, optimal blood pressure control, below 140/90, or if you have 1 gram of proteinuria, below 180 over 130 over 80. Use ACE inhibitor, angiotensin receptor blockers, start a statin, stop smoking. That's the standard of care. And it works very well, as we have seen in many studies like the STENO2, the Japanese DO-IT-3 study. It works. However, there is a residual risk. And that you can see from this slide, the renal study on the left and the IDNT on the right, proteinuric type 2 diabetic patients. And you can see that if you give losartan or irbesartan these patients, yes, you can do a lot of good. You can slow down the progression, but you can see there is a lot of residual risk. We have a lot more to do. Next slide, please. What should we then do? And what have we learned from the recent cardiovascular outcome trials? 17th of September 2015 was a very big day for the diabetes field. Why? Because the EMPA-REG outcome trial was reported, and this slide shows from a pre-specified secondary endpoint analysis that yes, a composite endpoint of new onset of worsening diabetic kidney disease is down by 39% if you expose your patient to either 10 or 25 milligram empagliflozin. Absolutely fantastic. We had not seen that before. after the ACE inhibitors, but it took 20, 30 years in between. Next slide, please. However, the empiric outcome trial was not a designed kidney study. It was designed to test the safety of empagliflozin in patients with type 2 diabetes and ask the question whether they cause cardiovascular disease. They don't. Instead, they actually reduce the 3-point MACE. But the renal endpoint was a secondary endpoint. But you need to test the hypothesis in dedicated renal trials. And that was done in the Credence trial. Patients with type 2 diabetes and kidney disease. And you can see from the Credence trial, the primary endpoint was combined cardiovascular and renal endpoint. At that time, people were thinking that maybe the heart is more important than the kidney, so they didn't want to leave out the cardiovascular death. And you can see that if you have a combined kidney renal endpoint, 30% reduction in the risk. But look at the next slide. If you get rid of the cardiovascular death and just look at the renal endpoint, is actually even stronger, so 34%. So the good news here is that in a dedicated renal trial, you can actually, with an SGLT2 inhibitor in this situation, the canagliflozin, you can actually reduce the risk of a composite kidney endpoint. And you can see that the composite kidney endpoint here is doubling or serum creatinine, end-stage kidney disease, or renal death. There are not many in any of these studies that come to renal death. Why? Because how define that? You should be on dialysis, but you refuse. So it's only a handful in all patients, in all studies. The doubling or serum creatinine is a very hard, tough endpoint. It's a 57% reduction in eGFR, not 50, 57%. So it's a hard endpoint. But you can see in the Credence trial, fantastic news, 34% reduction in the risk of a composite endpoint. Next slide, please. And now you can press another time. One more. And one more. Okay, one more. Right. So you can see that the average patient in the Credence trial had an age of 63 years and an eGFR of 56. So, you know, about CKD stage 3. And if you then define the need for dialysis or end-stage kidney disease, an eGFR below 10, you can see that in the placebo group, it took 4.6 ml. So they lost 4.6 ml per minute per year. And if you then extrapolate these data, these are not tested, these are extrapolated from the Credence data, you can see that it would take about 10 years to reach the dialysis. Next slide, please. One click. If you look at what happened in the canagliflozin group, you can actually see that you reduced the slope was not so steep anymore. It was you lost 1.9 ml per minute per year, and it would take about 25 years. So what this actually tells us is that by prescribing an SGLT2 inhibitor to patient, we might be able to actually postpone the start of dialysis dramatically. Now, keep in mind, these are extrapolated data. This is not a 25-year follow-up, but it tells you that there is a potential. Next slide, please. The Credence data. Yeah, okay, so 15 years. Next slide, please. The Credence data were followed by another dedicated renal trial, the DAPA-CKD. And here you can see that again, a combined renal and cardiovascular endpoint, and down by 39%. So very similar data. They used a slightly different endpoint, sustained 50% decline in eGFR from baseline, end-stage kidney disease, renal or cardiovascular death. But you can see that very similar data as in the Credence. Now, there is a difference in the DAPA-CKD and the Credence patients. The DAPA-CKD patients had on average an eGFR 44. I said it was in the Credence 56. So slightly sicker patients here. Next slide, please. If you then look at very important finding in the on the left-hand side, so second from the top, type 2 diabetes at baseline, yes or no? DAPA-CKD actually consisted of 1/3 of patients without diabetes but kidney disease, and 2/3 with diabetes and kidney disease. And what you can see here is basically it works the same. So it's as effective in those without diabetes as in those with diabetes. And these are absolutely important and very, very good news. What is another difference between DAPA-CKD and Credence is that the DAPA-CKD went down to an eGFR 25, Credence to 30. That was a difference. However, both of the trials excluded one important patient group, and that is those type 2 diabetic patients with non-albuminuric kidney disease. 20% of all your patients will probably never ever develop albuminuria, and they are usually hypertensives, those with obesity and aging as an etiology for the diabetic kidney disease. Next slide, please. So, but those will be studied in the EMPA-Kidney trial with empagliflozin. So, and that study will also go down in eGFR down to 20. So, if you then look at the clean, the pure renal endpoint here, exactly as you saw in the Credence trial, it was even a stronger effect, and the same is true here. So, 44% reduction when you look at only the renal composite endpoint. Next slide, please. So that's the SGLT2 inhibitors seem to be one of the means to do something good to our patients, that we need to do something. I said we need to take action. The good news is also that a few weeks ago, we heard the news from another trial, the Fidelio diabetic kidney disease trial. And the Fidelio actually employed a mineralocorticoid receptor antagonist, so finerenone. And keep in mind that whenever you activate the renin-angiotensin aldosterone system, you will have the release of aldosterone from the zona glomerulosa in the adrenals. That will actually retain water and sodium, so reabsorption of sodium in the distal tubules and in the collecting ducts, and you will, by that, you will have sodium conservation, water retention. Now, that is also associated with the aldosterone release with inflammation, and not only inflammation but also fibrosis. So finerenone is in experimental animals shown that it can actually reduce fibrosis and inflammation. And what you can see here, when you expose patients with type 2 diabetes and kidney disease to finerenone, you can actually see an 18% reduction. So totally different mechanism than the SGLT2 inhibitors. Next slide, please. And have just a few more. And what you can see here, sorry, that seems to what that slide should show is that basically all the components of the primary kidney composite endpoints are left of the unity line. So that's important. Next slide, please. So, ladies and gentlemen, dear colleagues, a few take-home messages from what I said here. Next slide. So, first click, diabetic kidney disease is common. Next. The consequences of diabetic kidneys are grim. Next. Multifactorial treatment improves the prognosis, but there is still an unmet need. That doesn't mean that multifactorial treatment is not important. It is important, but there is more to do. And cardiovascular outcome trials with SGLT2 inhibitors have shown cardioprotection. I didn't show that data in the primary as a primary outcomes, but also renal protection in secondary outcomes on top of multifactorial treatment. But these are secondary outcomes. Next slide. But dedicated renal trials, so RCTs, have proven the renal protective effects of SGLT2 inhibitors, Credence and DAPA-CKD. Next. Mineralocorticoid receptor antagonist finerenone has also shown to be renal protective in individuals with type 2 diabetes and diabetic kidney disease. And then the absolutely most important thing to do now, next slide, implementation. We have now the means in our hands. We have seen a bunch of wonderful studies recent years since 17th of September 2015 with medications that are not only cardioprotective but also renal protective. But the next step is to implement, because you know that, for instance, SGLT2 inhibitors, the uptake on a global scale is 6%. So think about that. We have a lot more to do. Next slide, please. Next slide. Thank you for your attention.
Well done. This was a fantastic presentation. Thank you. Now, we have diabetes on the rise. We have long-term complications of diabetes on the rise. We have a new disease that puts diabetic patients at risk. We have means to work out to possibly delay or prevent diabetes, possibly delay or prevent complications. But I think we are not so good at doing this. We are perhaps failing, and this is one thing that I think I'll leave to the end, because this carries a sort of a political discussion over it. And I suppose that we may have some questions from the audience, and I would like to know if the people monitoring YouTube and Google Meet have something to ask, or if we can go on and just talk. Okay, so I have one question from the audience, and I think it's for Stephen. The question is: should metformin not be used in youth then?
So that's a good question. Today in the United States, there are 3 medications that are approved for treating youth with type 2 diabetes by the Food and Drug Administration. The one is insulin. That was the first one, has been around for a long time. Metformin is the second one. And last year, liraglutide was approved for treatment of youth based on a paper that was in the New England Journal of Medicine by Bill Tamberlin, which is an interesting read. The answer to the question simply is yes, we should still be using metformin. And most pediatricians will use metformin as first-line therapy. What happens is clearly that these youth fail. The Today study compared metformin to metformin and lifestyle and metformin and rosiglitazone. So essentially it was one drug versus either metformin and lifestyle or metformin and another drug. And the only difference was with metformin and rosiglitazone was better than metformin alone. But again, one would not give rosiglitazone to youth today because of the weight gain and all the things that we don't know that are happening in these young people that have become apparent since that study was done in terms of what we see in adults. So I would argue, yes, in answer to the question, give metformin. You can use it as first-line therapy, but expect failure with metformin much more rapidly than in adults.
Okay, thank you, Stephen. Now, a new question. I think this is for Pera. We have data on nephroprotection in patients with established chronic kidney disease. What about primary prevention?
Yeah, that's of course we don't have. I think these medications, two inhibitors, will definitely work also in primary. The reason why, if you look at all the data on the cardiovascular, when you stratify for renal function, albuminuria from macro, it seems that they work. Why do I say that they work? I think it has to do with the mechanism of work. These medications, they act on they block the proximal tubule. And by the way, you know that the proximal tubule has the highest number of mitochondria in the body. It be something for that. So block that reabsorption that seems saturated is then sodium, the macula densa, and by the same as the fruit works, this sodium reabsorbs the energy to ATP, and you generate, which regulates the tone of the afferent arteriole. Hey, that is how it. But why does it work? Yes, because you have hypertension, obesity, diabetes. What is? They all have increased renal blood flow. When you have an increased renal blood, you will have hyperfiltration. Anytime you have a filtration, the sodium handles the proximal tubule, so you absorb more sodium. And that the energy depots, but more importantly, it also depletes the kidneys get toxic. So anytime you have hypertension, obesity, and diabetes, will have kidney hypoxia. Now, important. If you induce it's an experiment on animals, within 3 days, these are hypoxic. If you give a drug called that makes the kidney hypoxic, what phenotype? Proteinuria, inflammation, cell damage. What we see in these, we see in that, we see it in hypertension, in obesity, and that 25% of the reaches the kidneys. Actually have to protect them against too much at the of hypoxia diseases. Darren McGuire, when the DAPA study was released last year, were you surprised? I said absolutely not. That they work also diabetic, because the mechanism is an increase of blood flow, you push the sodium, you run called kidney hypoxia, activate the sympathetic nervous system, you activate angiotensin aldosterone, etc., etc. And by blocking that, you get some good results. Not only in diabetes, but also in those without diabetes. So I think this is fantastic. And back to the question, I think if we can actually save money because of hospitals failure because of other problems. We need to start early. We need to implement. We don't do that.
Okay. Wow. Thank you. Now, Tara, your the final slide had a red line saying implementation, 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 and I think this is critical for what you are showing us. But I feel that this is even more critical when we are trying to prevent diabetes or the progression of diabetes to more serious stages. Now, the thing is, people, in our country we have a public health system that looks after over 140 million people. Most physicians are aware of the benefits of, for instance, metformin, but we don't see things like patient education and strategies for having people live a healthier lifestyle happening in this country. I mean, we are lagging behind, and I don't know what the situation is in both Finland and the US in this sense, but I think my feeling is that the entire globe is failing. And what can we as physicians and academics do to help the health systems and people who plan these things actually provide better care for our patients?
So I can start. Stephen can add to this. I just know that even ACE inhibitor uptake in the US, correct me if I'm wrong, Stephen, but I heard a few weeks ago that the uptake of ACE inhibitors in those that should have them is at the most 60% or even so. And we talk about medications that have been around for a long time, and then you ask the question, why is that so? So there are obstacles, and it could not only be that they are expensive or anything, because they are not that expensive anymore. They are run out of the patents. So we need to rethink, and I can tell you that the reason why I used the word here, we need to take action, is that I made a slide series about 20 years ago, which I called Microalbuminuria is not only a test result, it's a call for action. So we need to do something. But how to get beyond the barriers and to get the doctors to understand, not to start to discuss that should I switch this to another drug and so on, but we probably need them all. And then motivate people. That was the wonderful talk by Stephen, showing that yes, we can do a lot. But I think in the end, if the example from the DCCT, you remember that 1,441 patients involved in the DCCT, and they had 7% A1C in the actively treated group intensively, and the other 9. But what's never said in the papers is that there were actually more healthcare providers taking care of these patients. And you know what happened when DCCT stopped? Actually, the A1C emerged, and this tells us that you need a lot of efforts. And if you have people calling you and making sure that you are, it probably works. But we need to try to understand how to get people to understand how important it is to prevent onset of diabetes, and especially what Stephen was saying, these poor young guys. We need to prevent that develop type 2 diabetes, because if they do that, every second one, and in your country even more, are at risk of diabetic kidney disease. That comes with grim consequence. So we need to do something. Sorry for a long answer, Stephen. You probably want to.
Yeah. So everything you said, Pera, is right on. I think it's sad, but I think one's got to look at the United States somewhat as a unique situation. And why? Because politics is such a huge player here. Clearly, it's a player everywhere. But in many countries, the government is able to have some control over the pharmaceutical industry's prices, which makes it possible, for example, in the UK, that you can get lots of choices for medication. So in the United States, for example, I work within the Department of Veterans Affairs system. They've become a little bit looser in allowing newer drugs for glucose control, for example, like the SGLT2 inhibitors that Pera, you mentioned, have all these extra benefits, the GLP-1 receptor agonists, and they negotiate prices with the pharmaceutical industry. Outside of that, the patients who have their own private insurance or get private healthcare either have their own private insurance, and then it depends how much they pay as to what they can get access to, or they join groups, large groups, sort of like Kaiser Permanente as an example, where again, there's huge negotiation going on with industry, and where you don't necessarily get all the medications, or there's real restrictions on access to the medication. So that medications such as the SGLT2 inhibitors, and you're absolutely right, Pera, the uptake of ACE inhibitors is not what you would like to believe. They should be cheap, and therefore everybody can get them. But things like the SGLT2 inhibitors are going to be harder to get. And the sad part of all of this is that the people who probably most desperately need it, those individuals who are from underrepresented minorities in this country, who are socioeconomically struggling, therefore get more complications, premature mortality, and are the people who don't have access to these medications because they can't afford them. Or if they could afford them, when they find out they go to the pharmacy, the insurance is eating into the money, and the choices now start to become much more what to do. The one good thing about all of this politically is, aside from the pharma industry that has huge lobbying in Washington, D.C., within Congress, there's a group that's called the Diabetes Caucus that's really interested in diabetes. The sad side is the industry can lobby them further. So a lot of the changes that we hear about, even under the current administration, that we're going to roll back the prices, medicine's going to become accessible to people, doesn't happen. And we're a country that's relatively wealthy, so that when you go to the third world, if we want to call it the third world, where people are really struggling, very few of the medications are available, and things like sulfonylureas and metformin are the standard of care with some insulin. So I think this needs political change everywhere, but it does need a change, Pere, as you say, in the attitude of the physicians to understand what they're doing. And again, in the US, we have clinics where people are seen and reimbursements based on how many people you see. So people spend less time with their patients. And in places like Brazil, I'm sure, but I certainly know in Africa, you can go to a diabetes clinic and one physician's got to see 20 or 30 patients in a half-day session. That doesn't provide care. So we've really got to change the foundations of what we've got to do. And that attitude's got to start with the patient, with organizations that represent the patients, and physicians and healthcare providers who are supporting people with diabetes.
True. Yeah, I agree.
Rogerio, your microphone's off, my friend.
Yeah, it was. Fernando, how do you see the situation in this country regarding these previous comments?
So right, I think that something very, very good that happened this year, and this was generated by a research group from Porto Alegre that organized with the federal government the discussion of the introduction of new technologies on the treatment of type 2 diabetes. And we were able to, on these meetings, and with the performance of a meta-analysis and a cost-effective study to show the benefit of the new treatments for type 2 diabetes to the government. And the good news is that dapagliflozin was approved for the national health system for free for everybody that has 60 years or old and cardiovascular disease. And this will happen in the beginning of 2021. So I think that this is nice because there is a lot of criticism in Brazil about what we are doing with research, with the money of research that the government is spending. And this translates in a very nice result for and translation to the society. It's a real benefit for the society based on the research that we are doing.
Okay, thank you. I'm afraid we are drawing to a close. Yes, Stephen.
I'm sorry. One more comment, which I think just frames the problem in the US in line with what Fernando just said about dapagliflozin. In the United States, the Supreme Court yesterday heard an argument to get rid of the Obamacare, which allows people to buy insurance with pre-existing conditions in a marketplace that makes it more affordable if they don't get it because of their workplace doesn't provide it, because smaller companies don't provide it, etc. And there's an argument being made to get rid of it, which would be, in my mind, a total disaster. But those people who have healthcare through that system also will get medications to some extent. So you talk about dapagliflozin as being free in Brazil. If you came to the United States and didn't have health insurance and went to a pharmacy near my house to buy it, and you can look this up on the web, it would cost potentially $400 a month. And if you chose something like liraglutide, it can be $800 a month. Who can afford those medications? How are we going to do this without a healthcare system like in Brazil that makes healthcare a right, not an opportunity for you to purchase if you're lucky? And I think that's where some of the stuff that we have in our country, sadly, which claims to be a leader in the world, clearly does not lead in healthcare from this point of view.
Yeah. Okay. Well, thank you, Stephen. I'm afraid we are drawing to a close. So it was a huge privilege to have the three of you here with us, people that I really treasure, and you have made this a very exciting moment in our program. And I'll pass it on to Professor Ramos that will formally close the meeting.
Thank you, Professor Friedman. I want to thank you, Professor Ken, Professor Gershman, and Professor Brooks for this magnificent conference. I think the three conference was very, very, very explained, and you make a great run round today. So thank you for your time to bring us. I think we will finish by now.
Thank you.
Thank you.
Nós estamos fora do ar. We are out
Okay.
of air. Thank you, Professor Ken. It was